It's a great pleasure and a privilege to be here. And my first response, as Myron's, was to share with you some impressions coming off of yesterday's discussion, which was both exciting and informative for me. One of the, so I've added some content here to what I was going to present. Let's see. Wait a minute. Oh dear. Oh dear. No, I'm sorry, I'm going to go back. I think the first, I thought I had a picture of this, but I don't. I was reminded yesterday when we were talking about systems that it was very easy to lose the perspective of what it's like for the family. And I was reminded of a series that the New England Journal had. I'm sorry, I thought I'd put this in here, but I don't see it. A couple of years ago, they had a series on international perspectives on health. Each article in which was devoted to one country. They had one on Sweden, they had one on Brazil, they had one on Canada. And what particularly struck me was that this was a very useful format. I'd encourage you all to look at this again. It was the New England Journal 2 or 3 years ago, called International Perspectives, because it presents a very concise and comparable side-by-side way of looking at the way systems of care have developed in different countries. A particular feature of these articles was each article told the story of an individual patient. In one case, the patient was having pregnancy and childbirth. In the other, the patient was having a myocardial infarction. And it very much succeeded in putting a human face on what otherwise could have been a very administrative, economic, structural view of the healthcare system. So that's the first challenge. Look at that and see what you think about using this international perspectives format. But when you start thinking about using pregnancy and myocardial infarction as your prototype illustrations of how care works, when we come to autism, there are two things that strike us immediately in the face. One is, in contrast to pregnancy and myocardial infarction, which may both be relatively time-limited events, as Myron and others have said, we're talking about a lifespan condition. So my first challenge would be, as you think about telling the story of what you're doing in each of your countries using illustrations like this, like a case of autism, the first thing you have to be aware of is that it's a longer story, longer over a timeline than the pregnancy and the myocardial infarction. The second, and I think this would be extremely powerful, would be to present a case, an illustrative case in which a child or an adult was not served, and then one in which the individual was optimally served or well served. And the reason is, I think, behind all the discussions here about good systems of care and help for families, I think we're very aware, and there was some suggestion of this in the Lemonade movie yesterday also, of the tremendous burden, the unmeasured, unspoken burden which families with affected individuals are suffering over the long term. And so this gets complicated, but if anybody wants to take this up, besides just having an illustrative case from your country of how an individual with autism or ASD is served, think of two dimensions on which you really end up with four illustrative cases. One is ordinary and severe, and the second dimension is served and unserved. This would be very powerful to do, and I think it'd be very useful from an advocacy and marketing point of view as you try to develop support in your countries for this kind of service. And it's also very relevant to systems of care, because the care of somebody with autism, as we're talking about, in contrast to the myocardial infarction and the pregnancy, they are immediately interagency, multi-systemic conditions. The other reference I was going to make that also was just very recent, the Lancet had a series of articles on a new concept, at least it was new to me, called Syndemics. And Syndemics, as the Lancet developed it just a couple of weeks ago, is an attempt to tell the story of health conditions, looking not just at the traditional etiological factors, but also at the political, cultural, and the social context in which they occur. So that, just as one example, when they were talking about certain health conditions in the U.S. among Latin American immigrants, you couldn't describe these if you only looked at the traditional ecological or factors. You have to also consider the very fragile situation of the immigrant population in the U.S. as an example of not being able to examine a health condition except through this syndemic lens. So given everything we were hearing about yesterday about the proliferation of unregulated services and a free market that's kind of running on its own, sometimes the idea of a syndemic approach, I think, has a lot to advocate for it. The next section I wanted to mention has to do with the triple aim. And again, this is something which we in mental health have used less than our colleagues in general healthcare have used. Triple aim was developed by the Institute for Healthcare Improvement in Cambridge in Massachusetts, and it's a brilliant simplification of reducing pages and pages and hours of talk to three elements: health outcomes, patient experience, and cost per member per year. And the reason that it's so powerful is that it's so simple. It's called the triple aim. It can also be called the simple aim. And obviously each of these is pretty tricky to look at. But now just think what happens when we try to apply the triple aim to children and adolescents, especially to mental and behavioral health conditions. For instance, with regard to health outcomes, this is illustrated also by the point I was just making about the comparison with the myocardial infarction and the pregnancy. When we look at health outcomes, or outcomes in general for children and youth with behavioral health problems, we're talking about all functioning, not just physical health, and we're talking about the long-term, not just the current episodic outcome. We're also, when we talk about patient experience, the second part of the triple aim, we have to look at the experience of the parent, the family, as well as the child. And again, as we've heard about, and we'll hear about again and again, the triple aim, as it was developed by the Institute for Healthcare Improvement, was only looking at healthcare, at costs in the healthcare system. But none of us could have spent 5 minutes in these discussions yesterday and today without appreciating how these costs for the ASD kids are dispersed over agencies. Some costs borne by the family, some by the special ed system, some by the public welfare system, and some by the healthcare system. So this may be one of the reasons the triple aim has been as little applied in child mental health as it has, because it's much more difficult. So here, for instance, notice how the costs for those with ASD are spread over the health care system, the mental health behavioral system, special ed, I didn't mention social services, but of course residential, big time. And here's just one way to try to tackle this. For each life phase, however you want to divide the lifespan up, you could ask, what are the percents of these? And Myron was just speaking about this. In your current model and your ideal model, those who will be at home, those who will be receiving partial services, those who will be in residential, and those in the most expensive services. Now, this is an old figure that, and Myron criticized me for having the boxes here all the same size, but that's just to illustrate the concept, not what the numbers should be. But this is, again, from the point of view, when we're talking about designing a system, this is an attempt to get one's hands around the whole system to say for each age cohort, how many do we expect will be getting at home with no services? How many at home with community services? How many getting out of home care? And to do this across the lifespan. Again, because ASD has been primarily seen as a child and adolescent problem, it's the aging out that Myron was just referring to, and the tremendous challenges for the community, for the family, for the individuals of the later stages of the lifespan that have to concern us. Then one could do cost projections for each of these distributions, And James Heckman, who's an economist who won the Nobel Prize from Chicago, said there's more to gain by taking a comprehensive approach to early childhood development. And this is a figure which Heckman developed. Actually, Myron first brought this to my attention. This is a wonderful figure that shows by stage in the life cycle when you get your biggest return on investment. And Heckman's argument was that it's obviously the earliest interventions in childhood that, if you look at the top programs targeted toward the earliest years, preschool, schooling, job training. And Heckman was making this argument for the population in general against those who would, well, it's really an advocacy for earlier interventions earlier in the life cycle. So the question we're left with is, does this apply to ASD? Now, the problem, of course, here is that there are dollar costs, but there are other costs. And we were reminded of these yesterday again by the movie Lemonade. And this is another story that was just in the Lancet. It's quite a moving story. It's a written portrait of a 9-year-old in the UK, written interestingly by somebody from the Department of Philosophy in Bristol in the UK. And the title refers to a 9-year-old who has fetal alcohol effect and has a lot of adaptive problems as a result. But the perspective of the author is to consider what struggle this 9-year-old has to make in order to do ordinary things, to get up in the morning, to get dressed, to get to school, all things. And we saw this also in the Lemonade movie yesterday. And Carroll, the author, reviews Aristotle's definition of virtue and points out that Aristotle did not consider handicapped people when he talked about what constitutes virtue. When he says we're virtuous if we achieve socially expected goals without considering what it's like. And he gives the example, if somebody with pulmonary disease manages to walk to the post office, we think that's a big accomplishment. The question is, for somebody with a developmental condition like FAS, what's the comparable thought? The other larger thought I'd leave you with, again, is the point from patient safety and quality improvement. Every system is perfectly designed to obtain the results it gets. This is a very powerful idea, which is always worth remembering as we look at systems and what's happening. When we start to say, well, somebody's not doing a good job or somebody's not smart enough to say, wait a minute, this person is operating in the system that was designed to achieve this result. It's especially relevant here where you see the proliferation of the free market efforts, the privately funded efforts that we heard about yesterday. Another perspective here is that of Ron Heifetz, who is a psychiatrist but works at the Kennedy School in Boston. And Heifetz's distinction between technical fixes and adaptive challenges is very relevant to this discussion of autism. A technical fix is illustrated, for instance, by the idea that well, now there'll be let's say there's a vaccine for Zika. That would be a wished-for technical fix for Zika. And there are other examples in which medication or other, taking the handle off the Broad Street pump in the cholera epidemic in London in the 1840s was a technical fix. But if you look at it if there's not a technical fix available in that way, it's a much more difficult, this is what Heifetz refers to as adaptive challenges. Now, let's come to what I hope will be a treat for you, to talk about the particular contributions of mental health systems. Now, child psychiatry, like other specialties in medicine, brings the ethics of commitment, scientific inquiry, and teaching. But what's different, some would say, well, we're different because we prescribe the medicine, but I would say that's both inaccurate and unfair. Troubled children need a lot more. And what I want to spend the rest of the time here rather quickly sharing with you is our contribution, how we see troubled children and the voice we give to the child. And notice, for instance, how much in the last century and a half the traditional view of children has changed. Here are three representatives from Western Europe and North America of the course of 150 years, how some of the most popular books about children changed from this awful Struwwelpeter in Germany to Pippi from Scandinavia and, of course, Anne of Green Gables from Canada. a completely different representation of children. And we've moved from the idea that children should be heard and not seen to one of our forebears in Boston, William Healy, who coined the phrase the child's own story when he first started working in the juvenile courts in the first part of the 20th century. And now we have these expressions, voice and choice, and nothing about me without me. Now here's just to talk about the voice of the child. Let's come back to autism. Is there a voice to hear and how to hear it? Yesterday we heard a little bit about this. Well, of course, we have the materials here from the Dubai Autism Center itself, which are just terrific to look at online and to appreciate how humanizing an approach this takes. In addition, we have now kids doing theater, the ASD theater group, and as I think Bennett mentioned yesterday, the popular TV show Sesame Street in the U.S. is going to have a girl with autism on it as a character who says, "So I'm amazing too." Then there's a group called Artists with Autism, and I want to share with you a story which the grandson of a colleague of mine with his mother developed 20 years ago, almost 20 years ago. I heard my colleague mention that her grandson had autism, and then the next I heard was that he in his early 20s had founded an organization called Artists with Autism and produced this book, which I will go through very quickly because of our time consideration. But his nickname growing up was Papa, and so he produced this with his mom. His name is Andres. Produced this book, What's Wrong with Papa? In a little blue house on the top of the hill lives a little boy named Papa. He loves snuggling with his mama. He loves cooking dinner with his grandma. He loves wrestling with his Uncle Fig. And Papa loves his twin sister Alex so much that he sometimes takes a bite out of her braids. Most of all, Papa loves his trains. He likes to set up his tracks all through the house. He likes to spin around and around with his trains. He likes to lay on his belly and sing choo-choo, choo-choo with his trains. And when Mama tucks him in at night, his trains get tucked in too. Sometimes Papa gets scared of dogs and bees and loud noises and too many people. He gets scared at school, at the park, at the mall, and the doctor's office. And when he gets scared, he cries and yells and bites and runs to find a quiet place to hide. Mama takes Papa to the doctor and says, "What's wrong with Papa?" The first doctor says, we heard about this yesterday too, "He's just a growing boy, don't worry." The second doctor says, "Give him this medicine." The third says, "I think we need more tests." Mama didn't know what to do, and Papa was very sad and scared all of the time. He didn't want to snuggle with Mama or cook with Grandma or wrestle with Uncle Fig. He wouldn't even bite Alex's hair braids anymore. All he wanted to do was to play with his trains in a quiet, hiding place. One day, the teacher, Mrs. Johnson, said, "Maybe it's autism." Mama did not know what autism was, so she went to the library and checked out some books. She talked to other teachers and parents and met some autistic children. They reminded her of Papa. Some kids were spinning themselves, and some were spinning toys round and around and around. Some lay flat on the floor to play, and others liked playing with puzzles and patterns. Mama learned that children with autism come in all shapes and sizes, are able to learn and grow, and are special, like all children. Mama talked with Mrs. Johnson, with Grandma, with Uncle Fig, and even Alex. They decided to make some changes to help Papa. They made a family schedule and a school schedule for every day. They kept noises down. They talked and read books with Papa about dogs and bees and crowds. They gave Papa warnings when changes were coming. But most of all, they gave Papa all of their love. Papa tries hard, and when he gets nervous, he holds his favorite train. Sometimes he is still too scared and sad, and he runs to find his quiet place. But soon, he begins again to struggle with Mama and cook with Grandma and wrestle with Uncle Fig. And yesterday, he even got a big old juicy bite of Alex's braid. and Mama finally knew that there was nothing wrong with Papa at all. So what's the takeaway from this? First, I think this is a terrific example of a sympathetic view based on a scientific understanding of mechanism and an empathic diagnosis how the child feels. It sees the child as an agent, not just an object. It's a shared narrative of mother and son. I think it's terrific. It illustrates the use of art in education and offers practical steps of what to do. That's how you can reach me, and say shukran.